Our next speaker is Dr. Chelsea Bond, Senior Research Fellow up at Poach, Queensland, and Chelsea over here is well known, and particularly for her radio program, Wild Black Women.
Not yet.
Yeah, a little plug, if you want to listen to it, but no.
Look, as a Mananjali woman belonging to the Yugambeh language group, I want to thank Brother for welcoming us here today. I want to thank you, Tom, for the plug for Wild Black Women. I want to thank Dennis and the Adelaide Poach for bringing us together to have this kind of conversation. We don't get to have these a lot, and it's really important that we have this kind of dialogue. I also want to acknowledge the emotional discomfort these kind of conversations have, and not for non-Indigenous people, but for the Indigenous people in the room who have to bear witness to the brutality of the health system again. And these stories are very familiar to us. And so as I was sitting here listening, we feel it. It's the embodied discomfort that we carry as Indigenous people. And so I hope that in what I yarn about today doesn't... I just want to acknowledge that in the course of having this conversation about what it does. In terms of positioning myself, I was trained as an Aboriginal health worker, and I worked in health not because I believed that... not because I wanted to be a health professional, but I was concerned about the violence upon Indigenous people in this country and what do we do about it? And health was just a pathway in which I could kind of think about tinkering with the world that we live in and make it a bit better and a bit safer and a bit more, I don't know, change some stuff because it's not working for us very well, and it should. If it's going to work for someone here, it should be for us. So I worked as a health worker. I worked in tertiary settings as the hospital liaison officer. I worked in primary health care and as a community health promotion worker. So I got to see the brutality of the health system in all kinds of wonderful and interesting ways, whether it was in the hospital system or in community health practice. And so I was really, I guess over the years have become increasingly interested about the absence of care in the healthcare system for our mob and wondering why that is. And I now work in health education space and I encounter all these students who are claiming to be taking up a profession because they care. And I'm just wondering why there's an absence of that when it comes to our mob, when it comes to our bodies. So that's kind of, I've kind of become more interested in race. That's kind of led me on the path. And I've been fortunate enough to get a research fellowship where I'm looking at how race operates within the health system for us, on us, in all of its wonderful ways. And looking at post-2000, in the time of Close the Gap, where apparently everyone's committed to making things right, let's look at how racist this whole thing is. I mean, Close the Gap in itself is inherently racist in that the norm that we must aspire to is whiteness. Like, that's a problem. But anyway, what I thought I'd do today is just do a few little provocations about the barriers to outing unconscious bias. It's not exhaustive, not extensive. I kind of whipped it up this week, but hopefully it will help the yarn we're going to have after this, yeah? So I wanted to just acknowledge the people who did this. Our current National Aboriginal and Torres Strait Islander Health Plan has as its vision a health system free of racism. And I'm cynical about that aspiration and whether that's even possible, but the fact that it's there means that we get to have these conversations, because prior to that being in the plan, we couldn't say the R word. But now we can. When we sit with the minister, when we talk about curriculum, when we apply for research grants, we say, well, this is the vision, so give us the money to do this work, which is cool. So I want to acknowledge the mob that fought to get that in there, because that wouldn't have been easy. What's interesting is the contradiction here in terms of health research. So we have this vision of a health system free of racism, but I'm not sure where the evidence base is that we call to make that happen. So if you look at the NHMRC funding over the last 15 years, only 5 out of 733 research projects that explicitly have Aboriginal Islander health as a field of research code explicitly mentioned racism. That's 0.17% of like the 5 or 6% that the NHMRC boasts that they spend on our health. So it's kind of interesting that one of the largest health gaps in this country that we're all really committed to right now doesn't actually look at race as a category of analysis in order to fix it. So it makes me think about, well, what is the gaze then upon us? What are we then examining in understanding health inequality then? And what kind of racialised knowledge is being reproduced under the guise of close the gap? What are they saying about our bodies to explain away our sickness? Which is much as what I guess Barry was talking about, the way in which the state almost has its alibi already. It's the deviant Aborigine, it's the uncompliant native. Somehow we did this to ourselves. So another barrier to outing unconscious racism, so of course the lack of evidence. Barriers to, one of the barriers to me is I think that there's this position that the health sciences maintains that somehow race isn't real, so that's why we don't look at it. It's not a real thing. Yet the health sciences have had a long tradition of making race real and making all these kinds of racist claims about Indigenous people under the guise of, health and medical practice. So it's a kind of interesting contradiction that that they would claim this. I think in the health sciences we lack the tools for understanding race. There's an approach to race at the moment within the health sciences that tries to quantify and measure it as though it's this aberrational behaviour that can be remedied or eradicated, much like smoking. But race doesn't work like that, and I just want to refer to Goldberg, who says the labour of race is the work for which the category and its assumptions are employed to affect and rationalise social arrangements of power and exploitation, violence and expropriation. Race was turned into a foundational code. It had to be cemented in place. And it was the scientists, the philosophers, the writers and literary critics, public intellectuals and artists, journalists and clergy, politicians and bureaucrats, for all intents and purposes, became the day labourers, the bricklayers of racial foundations. So in order to undermine and disentangle that, then we've got to do more work than 0.1% or 5% of research to make sense of this. And we can't claim that the health sciences are not complicit in the violence that's been perpetrated against Indigenous people in this country, that health and medical practice was not an apparatus of colonial control. I mean, I only think back to the 1930s, in the time when my grandmother was a young woman, and in Queensland health, in government reports, gin was a source of contamination category for STDs. Now, look at how the health system gave an alibi for the sexual exploitation of Aboriginal women under what we knew was the Protection Act. Look at its complicity, but we don't do that. We claim this notion of benevolence. I think one of the other barriers to thinking about, I should point out, I'm an anti-racist. I think we have to let go of the whole anti-racism thing. It doesn't work. It's not about feelings or attitudes, whether you like someone. It traps us from actually getting to dismantling the bricks of the house that's been built here, and it's a distraction. Culture is also another distraction and a decoy from us having proper yarns about race and how it works. So the kind of new racism now is we talk about culture. So we don't talk about genetic predispositions. And I mean, I was trained under the time where we were still talking about thrifty gene theory and stuff. That's why we had diabetes. So this is quite bizarre. But now we talk about culture. So it's because of their culture that they are unwell. It's because of their attitudes towards health and health care that they're not compliant. And so we make all of these racist claims via culture. And culture also is an alibi then, because we're talking about their culture and we're just appreciating their culture. It works really nicely. It makes racism seem so polite and civilised. So we see race has been abandoned in favour of culture, and I always get cynical when I hear people talking about culture, because I want to know what that means and what are the racialised claims they're making via that logic. So culture has been used to mask the material impact of race as a social construct. It sees the reproduction of racialised logics via behaviours and practices. Sorry, I didn't realize all these separate dots. Let's get to good intentions, because we have to talk about those a lot. And if I look at blackfellas, then we know that we've had to deal with the good intentions of white people all the time, even in our work. Even in our work in being committed to do away with racialised health inequalities, we often are required to centre the intentions and emotions of our non-Indigenous colleagues who mean well, and we should be grateful for their assistance. Good ways. Yeah, we know them. So these claims of good intentions to sustain indifference to actual outcomes is a real problem, and we need to do away with that. And I actually think outing the whole notion of unconscious bias is part of an apparatus that maintains the intentions of the discipline. Because apparently racism is unintentional, and therefore it's not as bad. Racism is not unintentional. The system's worked really well. And it's a well-oiled machine. It doesn't require intention because it does its job, does what it's meant to do. So I'm really over conversations about good intentions like Barry. I think if your feelings are hurt, you need to go see someone and not make the black person in the office do that work for you, because that's not what we're here for. We're here for our mob. So I think good intentions are a real barrier. I think we need to think about the language we're using when we're talking about racism too, and whose feelings we're centering when we police our language around race and racism. Fanon points out, medical science and concern for one's health has always been proposed or imposed by the occupying power. In the colonial situation, going to see the doctor, the administrator, the constable or the mayor are identical moves. The system works really well together to make these outcomes possible. And it really struck me, I think, with the case of Miss Dhu, in that everyone thought about the justice system and the horror of the justice system and the ease in which she was able to get into the justice system. But there wasn't enough scrutiny in my mind to the health system that turned her away, that refused to care for her repeatedly, that insisted that she was nothing but a fucking junkie. In the words of those who claimed to care for her. What's interesting also with these cases, though, is the brutality doesn't just end there. And it is, Barry talked about kicking the dirt of the graves. We see that in our coronial inquiries here in this country as well, and what they do to assure us of the intentions of the state, the good intentions of the state. We have our own cases. Miss Dhu's not alone, sadly. We have the Coolwell brothers in Logan Hospital. We have Miss Hookie in New South Wales, Miss Williams, Miss Weasel in Cherbourg Hospital. And we also can see in the coronial inquiries the way in which they are further dehumanised. So they in the coronial reports, they are not well-rounded characters. They're barely human, even in death. We'll see that their introduction to their story starts with health behaviours, sexual promiscuity, criminal history. They are rendered deviant. Even though the conditions, those things that are outlined there have nothing to do with how and why they died, we are told that they are somehow complicit in their own death. Even in these cases where people are just refused care, where a partner has to rip a railing off the emergency, in front of the emergency of a hospital to get attention, and the attention he receives is not an ambulance, not a doctor or a nurse, but a police car to verify that they're actually legitimate clients of the healthcare system. So very fortunate to have a PhD student, Helena Kajlik, who's doing some work within our Poach Centre, who will be looking at some of these coronial inquiries and what they do and how they work, and to reveal the brutality of the health system. And it's a really uneasy thing to be doing as a black fella, to exhume these bodies. It's not easy work, and there's a danger in what we're doing with this stuff. And I think about Emmett Till's mum and why she chose to show his body. She wanted to show what they did to her boy. And so we have this really uneasy thing of going, we live the violence and then we have to reveal it in the hope that our wounds will somehow speak to a system that's refused to see us and refused to care for us. So yeah, outing unconscious bias is really hard work. It's hard work for black fellas because the toll it takes on us is really hard. Okay, I'm going to finish up. I'm nearly there, hey? So what can we do to fix this? In like 4 easy steps. I had 15 minutes, geez. I think what we need to do is work toward a race-critical health agenda and be explicit about that, because we need to. We have to recognise the realness of race and racism, both as an everyday experience for Indigenous peoples, and we need to stop discounting it, downplaying it, trivialising it, minimalising it. We need to recognise it also as academics as a legitimate category of analysis within research, and not just to tell us how many of us smoke. Not just to tell us about the high rates of discharge against medical advice. Maybe we can check the emergency room waiting times along the lines of race. I wonder what that might tell us. Currently, the government gets reports on discharge against medical advice. Because what is it telling itself? The natives are not compliant. If they just cared about their health, maybe we could change it, and we'll do some workshops to teach them how to care about their health, because clearly they don't. We need to make explicit the brutality of the health system upon Indigenous peoples and take care of ourselves in the course of that, of course. I think what we need to also do, and I think this is the thing that I guess is really exciting me, is how do we develop the racial literacies of health science students rather than focusing on cultural awareness and cultural competency. I know as a student of the health sciences, I was not trained to understand how race works. And it's only teaching in Indigenous studies and in the humanities, getting a sense of, hang on a second, there's something here, and how do we bring that in? Talk to health science students when you look at concepts like identity, race, culture, ethnicity, it's really bad. The understanding is really bad, yet we trade in them to visit violence upon particular groups of people in this country every day. We need to move beyond our own emotions, intentions and virtue. We know the health system hasn't been caring, and it still refuses to care and refuses to see us. We need to stop being the alibi for that. Like if we genuinely care about closing the gap. Sorry, I'm getting a bit cynical. And lastly, I think what we need to do work towards, and I think it's really possible, but it's an ongoing process, is we need to work towards fostering the necessary political and intellectual environment that's capable of producing a health system free of racism. We can't actually get to the vision unless we create the landscape for it to happen. Part of that is having these kinds of yarns like this and us doing our own work. So I have to look elsewhere to kind of help me think about how to do this work here, because we've long been trained in this country to not speak about race. To not get too political, don't be radical, but we can't afford to be silent. So that's it for me, yeah?